Hello everyone, my name is Nitin. I'm one of the chief residents currently in New York Medical College, soon to enter cardiology fellowship at the same program at St. Michael's Medical Center. I have with me Dr. Soo Kim from Korea. He is the current Cardiology Society President of Korea, and he's here to share his thoughts and his paper, 10-year follow-up of Clopidogrel versus aspirin in stable coronary artery disease after PCI with drug-eluting stents. Good afternoon, doctor.
Yeah, good afternoon. I'm H.S. Kim from SNU Hospital.
So, he just finished this session about the paper, in the late breaking clinical trials, and he was bummed in with a lot of questions. He's just here to, answer us few questions for the students and the fellows. My first question would be like, what clinical uncertainties, led to the extension of the host exam trial, which was already released a few years back, to extend the trial?
Yeah, in host exam program, we reported for the first time 2-year results of Clopidogrel versus aspirin monotherapy as a chronic maintenance monotherapy after DS implantation. At 2-year results, Clopidogrel was better than aspirin in terms of primary endpoint patient-oriented composite outcome, including all death, myocardial infarction, stroke, readmission due to ACS, and major bleeding. As well as Clopidogrel was better than aspirin in terms of composite thrombotic endpoint and any actionable bleeding. But such a SAPT, single antiplatelet therapy after chronic maintenance period of PCI, should be prescribed lifelong for patients. Thus, 2-year results may not be sufficient to confirm its safety and efficacy long-term wise. That's the reason why we pursue the follow-up of these more than 5,000 patients up to 10 years.
Okay, thank you, doctor. Obviously everyone post PCI need to be on single antiplatelet for a long time, so definitely the study makes sense extending the trial. My second question would be like, what subgroup of patients you felt in the study, who got the most benefit out of Clopidogrel compared to aspirin?
Overall, the 10-year results have shown that Clopidogrel was better than aspirin, not only in terms of primary endpoint, POCO, but as well as in composite thrombotic outcome and any actionable bleeding. The remarkable benefit of Clopidogrel was well demonstrated by huge risk reduction of myocardial infarction, about 40% in PP population, major bleeding reduction by 40%, stroke by 50% in per-protocol analysis. Thus, huge reduction of Clopidogrel was achieved in comparison with aspirin for 10-year follow-up. We did the subgroup analysis, and most subgroup consistently favored Clopidogrel over aspirin. But interesting finding was observed in PP population subgroup analysis. We noticed most remarkable benefit of Clopidogrel was observed in both high-risk population, such as high thrombotic or high bleeding population. In other words, the thrombotic benefit of Clopidogrel was more pronounced in subgroup with high tendency of thrombosis, such as after complex PCI, young obese male subgroup, while the benefit of risk reduction of bleeding by Clopidogrel was more pronounced in subgroup with high tendency of bleeding, such as high bleeding risk population or CKD population or elderly underweight female subgroup. Thus, overall, all subgroup favors Clopidogrel, but the benefit of Clopidogrel was remarkable in both extreme high-risk subgroup, thrombotic risk group or bleeding risk group.
Thank you, doctor. My third question would be, one of the common questions you might have faced here, considering the population the study population was predominantly East Asian. How would you think the generalizability of this study would affect, especially considering like differentiable Plavix metabolism in like, genetic mutations, and especially the incidence of this higher in East Asian population?
Mhm. Yeah, definitely there is an issue of clopidogrel resistance. Uh, yes, actually we have higher prevalence of poor metabolizer of clopidogrel. Thus, we have higher absolute value of PLU on the treatment than Caucasians. That is called as laboratory resistant against clopidogrel. But actually, in numerous clinical trials done past 20 years, have demonstrated the thrombotic event in East Asians is really less than that of Caucasians, less than half. Thus, we believe there is a definite gap between laboratory resistance versus clinical resistance against clopidogrel. Thus, we don't believe clinical resistance of clopidogrel because recently we experienced a series of clinical trial in ACS population as well as AMI population, where we reproducibly observed benefit of clopidogrel depth than ticagrelor depth, such as TICA Korea ACS trial and Talos AMI trial and Korean AMI registry trial, as well as Japanese Philo RCT. Thus, we believe the clopidogrel is a very good drug to meet the sweet spot of good balance between the thrombosis and bleeding. That's the reason why about 8% of our population were treated with clopidogrel depth just before randomization to SEPT, even though about 75% of our cohort was ACS. That is a current practice pattern in Korea as well as Japan. Thus, I think even though this is performed in clopidogrel versus aspirin, we believe clopidogrel is very appropriate medication to meet the balance. How can you apply this finding obtained from East Asian to Western people? As I mentioned before, the thrombotic benefit of clopidogrel is more pronounced in subgroup having higher tendency of thrombosis. As we all know, the thrombotic event in Caucasians higher than that of East Asians, more than twofold. Thus, I believe the thrombotic benefit of clopidogrel would be more pronounced in Westerners than East Asians. Thus, I believe it is very highly possible to apply these results to Western people.
That was my inference, doctor. Probably we'll see more positive results if the study happens in the Western countries.
But this issue is very important because I believe it is very hard to run such kind of study in Western part because there is no sponsor. Because clopidogrel Plavix patent expired many years ago. Thus, it is very difficult to raise a sponsorship for such kind of trial. Thus, I believe there is no possibility to do such kind of RCT in Western world.
Okay. Thank you, doctor. My last question would be, is there any reason to still prescribe aspirin, for the following the dual antiplatelet phase? Any reason to continue with aspirin, or like what guideline changes do you think we should proceed with based on this study?
Yeah, still there is inertia of aspirin prescription because it was experience of about 50 years. Thus, we have to change because there are many reasons why we should change the medication from aspirin to clopidogrel. The first capital trial performed in Western world was published 30 years ago in Lancet. But that was not translated into guideline change because they enrolled heterogeneous population, not only PCI but also non-PCI group. The second, the effect of clopidogrel was modest compared with aspirin. Just risk reduction of vascular death, infarction, stroke was 7%. At that time, price of Plavix was very expensive. But now we show the evidence in a very specified population, DS implantation population, and there's huge reduction of risk of MI and stroke by 40 and 50% in clopidogrel than aspirin. As you know, MI, stroke, even though there is no total mortality difference, MI, stroke is very serious disease that affect hugely on the quality of life of your patients, lifelong. Huge reduction of major bleeding by 40% with clopidogrel. That is really associated with compliance. Adherence rate of drug is very high in clopidogrel arm than aspirin. Adherence to drug is very important factor for secondary prevention. Finally, price of clopidogrel is very affordable nowadays. In fact, in UK, the price of clopidogrel is same as aspirin. This is the really right time to apply these results to change of guideline.
Thank you, doctor. This was wonderful. I'll be starting my fellowship soon, so I wanna ask a question for all of us fellows. Any suggestions for like fellows in training? Having a life all ahead as a cardiologist. With your experience, do you have any suggestions?
Yeah, it is hard work to be trained as a cardiology fellow, but please enjoy your training course, not only in practice, in clinical practice, but also research. I've done research, not only clinical, but also basic research, but it is now impossible to do both tracks. Please select the specific thema. It may be impossible for you to do basic research. So for example, to focus on clinical research, among clinical research thema, you have to focus several subjects. Then such kind of treatment may let you be a kind of specialist or big shot in the 10 or 20 years later.
Thank you, doctor. Thank you. Means a lot. I want to thank Fit to Go committee out of the ACC, for giving me this opportunity. And thank you for coming from Korea, doctor.
Thank you for having me. Yeah.